Good morning, students. We'll be talking about applied anatomy of spinal cord. As you all know that spinal cord conducts the action potentials generated by various receptors on their stimulation from periphery and conduct these impulses through the nerves into the dorsal root ganglion, and these impulses ascend in the spinothalamic tract to the parietal lobe for further processing. Similarly, the brain sends its motor impulses through cut-co-spinal tracts in the descending tracts of extrapyramidal also, and they will home on to the ventral horn, anterior horn cells, and through them, through the lower motor neuron, they enter the muscles at neuromuscular junction and carry on the motor function. So spinal cord is a very important organ to study. So we'll start with embryology, a bit of the spinal cord, and there are three classes of spinal cord, and followed by we'll try and conduct a seminar where the students at the end of the three classes. So the first class deals with embryology and the applied neuroanatomy, and towards the end we'll talk of the diseases of spinal cord and especially the compressive myelopathy. The myelon or the spinal cord disorders are classified into compressive myelopathy, non-compressive myelopathies. And apart from that, the plexus that take origin from the spinal cord or cervical plexus, lumbosacral plexus also are subjected to various ailments, and these also you'll have to learn. So the first thing that you have to understand is right from embryology, you should know the spinal cord because it has ramifications in clinical assessment. The entire nervous system originates from the neural plate. Yes. Embryologically, the neural plate, okay, arises from ectodermal thickening on the floor of the amniotic sac. About third week, this neural plate forms paired neural folds which unite in the midline to form neural tube and neural canal. This process of neural tube formation is called neurulation. Cells at the edge of the neural fold escape from the line of the union in the midline and form neural crest along the sides, and which gives rise to the spinal autonomic ganglion cells, Schwann cells that lay myelin on the nerves, and melanocytes. So that's in the beginning of the embryology of the spinal cord. The alar plate is the dorsal part of the neural tube and receives the dorsal nerve roots arising from the spinal ganglia. The nerve roots at the posterior aspect of the spinal cord to the spinal cord, and the basal plate is the ventral part of the neural tube, and this gives rise to ventral motor roots and motor neurons, and these motor neurons carry the action potentials that are originating from the cerebral cortex and the brainstem to the motor neurons, and they carry out the motor tasks. And so you can see that at 3.5 weeks, at 6 weeks, at the 7 weeks, you can see the neural tube, the alar plate, which we discussed, the basal plate, and you see the posterior. This is the gray matter, and you see the posteriorly the sensory dorsal root ganglion is carrying the sensory impulses, and the ventral is carrying the motor impulses. And this is a ventral horn, this is a marginal zone, this is a dorsal horn. So this you keep in mind in the further anatomical positions. What happens? The spinal cord is occupying the length of the vertebral column, that is the bony canal. At 0 to 12th week, the spinal cord occupies the full length of the vertebral canal. But what happens in this process? A regression of the caudal end of the neural tube starts around 8th week, and it forms a neuroglial thread called the filum terminale. This is the last part of the spinal cord. At 12th week, the vertebral column, that is a bony column around the spinal cord, grows very rapidly and drags the spinal cord upwards. What happens at birth? The tip of the spinal cord is at L3 at birth, and at 2 months it reaches the adult position of L1 or L2. That means the end of the spinal cord is at L1 or L2. That's the thing which you have to know. You see the diagram. 8 weeks of gestation, the spinal cord is fully occupying till this is the spinal cord. Okay, at at about 14 weeks, you see there is the caudal regression. This is the phylum terminal that is appearing, and as the at birth you see that it is fully formed, and the spinal cord is about L. Spinal cord is at L1 level in adults, and these are the diagrams which will give you a clear picture of that. The spinal cord, the bony segmental and vertebral levels are compared because there is a regression of the caudal end of the spinal cord. The spinal nerves, which are from one the remaining spinal nerves, one vertebrae, and here is lumbar segment, first sacral segment, wherever it is from the below this, right? So you can see there are enlarged cervical at the lumbar enlargement, and these So the sympathetic and parasympathetic neurons also they supply various organs to the spinal cord. So that's it. That's the diagram which I'm trying to show you. Then we'll discuss more later about this. Right. Okay. Next, the neural arches and the spina bifida. So some of the diseases of the spinal cord, they have origin in their birth on it. From the fifth week, the mesenchymal vertebrae surrounding the notochord gives rise to neural arches, which provide protection to the spinal cord. The arches are bifid initially and later fuse in the midline to form the vertebral spines. Mind you, the vertebrae are anteriorly placed, the spinal cord is posteriorly placed, and all around the spinal cord there are pedicles which join to form the spines and vertebral spines. Failure to unite results in spina bifida. So there is a spina bifida occulta, which you can see that it is not connected here. There is a cyst which is protruding through the back, and there is a myelomeningocele, and there is a myelocele. There is a neural plate itself. So you got spina bifida varieties, spina bifida occulta, because the plates didn't unite in the midline, meningocele, myelomeningocele, and myelocele. You can see the example. The frog-like posture is characteristic of a combined femoral and sciatic nerve paralysis, and with the preservation of hip flexion, which is by the ciliopsoas, and you can see the myelomeningocele on the backside. So one of the important general examination findings in neurology is to look for neurocutaneous markers and examine for the lumbosacral region for a tuft of hair or a sinus, which will tell you that there is a possibility of congenital spinal cord or spinal dysraphism, as it is called. You look at the dimensions. Now we have finished the embryology. Now we are going to the spinal cord proper. Bony vertebral column protects the spinal cord, and its length is about 45 centimeters or 18 inches. And it is, as I said earlier, at birth, the lower border of the L3, and its tip is L1 to L2 vertebral disc level after 2 months after the birth. And look at the diameter of the spinal cord. It is varying in cervical and lumbar regions. It is 13 millimeters or 1.3 centimeters or half an inch. And cervical, the AP diameter 8.8 and 12.4, and the cervical enlargement extends from C4 to C6, that is 8.7 into 14 millimeters. Then the lumbosacral region has a lumbar canal, which is 15 to 27 millimeters. Similarly, cervical canal diameter, if it goes less than 8, or it causes compression on the spinal cord, causing cervical compressive myelopathy. So that's a understanding which you have to develop here about the dimensions of the spinal cord. I hope you are all clear about it now. If there is any doubt at any time, please stop me and you can raise your hand and question. All right. So the spinal nerves are 31, which are originating from the spinal cord: cervical 8, thoracic 12, lumbar 5, sacral 5, and coccygeal 1. The C1 root, this exits between the skull and the atlas. C2 to C7 above the numbered vertebrae, C8 above T1. The remaining spinal nerves will exit below the vertebrae of the corresponding number. Okay. And now you look at the vertebral body. This is the vertebral body which is anteriorly placed, and this is the pedicle. This is the superior articular process which anastomoses with the vertebra above, and this is the transverse process, and this is the spinous process about which we just talked, and spina bifida discussion we had. This is the intervertebral notch, and this is the inferior articular process which will, this is the lateral picture of the vertebral body or vertebral canal, and in this, through this, the spinal nerves will come out. And you can see the same picture. You can see the intervertebral foramina here, and this, as I said, is inferior articular process, and this is the superior articular process, and this is zygophacial joint or facet joint. This is called the facet joint, zygophacial or facet joint. So this anatomy is clear, I suppose, and this is a spinous process, and which will help in the movements, and this is a transverse process, and this is a vertebral. This is the canal in which the spinal cord lies, which is about 1.3 centimeters or 13 mm, and maximum in the lumbar, which is 2.7 centimeters. If this canal diameter is narrowed, then the problems start. You see the spinal cord now, which is large in the bony canal, and it has got a dorsal root and a ventral root which join to form. This is the dorsal root ganglion, and we join to form the nerve root, the spinal nerve. And this spinal cord is surrounded by meninges. There is dural space, there is a subdural space, there is a subarachnoid space. The pyometer closely adheres to the spinal cord. And arachnoid is durometer, as you know, all these three in the respective. And the dorsal root ganglion is conducting the sensory impulses from the body. So you can have a clear-cut idea about the spinal cord here, the ventral ramus and the dorsal ramus. This is the spinal nerve. This is spinal nerve. So the point to understand is that the ventral roots are motor, the dorsal roots are sensory. The sensory is afferent, the motor is efferent. Both are in the spinal nerve, which exits through the intervertebral foraminae and divides into ventral ramus and dorsal ramus. This dorsal ramus goes back and supplies the paraspinal muscles, and the ventral ramus of cervical region forms the cervical plexus. Lumbosacral region forms the lumbosacral plexus. And you see, whenever there is degeneration sets in, this is the osteophytes that are developing and they are pressing on the exiting nerve root. This is a facet joint. This is a facet joint which we discussed earlier between the articular processes, and this is a vertebral artery here. This is the synovial joint of Lusca, and this is the disc which can get prolapsed, and this disc can get prolapsed and cause pressure on the spinal cord. And this has got two portions, nucleus pulposus and annulus fibrosus. So the cervical, the canal of the vertebral column is narrow in the thoracic region. It is quite wide in the lumbar region and also in the mid cervical region. And you can see the spondylosis changes. As I said, these are the spondylosis changes, which on the axial section, you are seeing that the facet joints are developing osteophytes. The facet joints are present between inferior and superior the facets, and these are the articular processes. So you see the disc which I am saying can prolapse and cause pressure on the nerve root, giving rise to radicular pain. This is a calcification of the posterior longitudinal ligament. As I said, the spinal cord is placed posteriorly. The vertebral bodies are anteriorly. In between two vertebrae, there is a disc, and disc has got annular fibrosis and nucleus pulposus. Pulposus can protrude in the, if it is this is the ligamentum flavum that is posterior to the spinal cord, and you can see the arthropathy or the degenerative changes which are pressing on the nerve. So this is a disc herniation which is depicted here. So this can cause pain and cervical spondylomyopathy. You can see SAG section, the SAG section canal and causing pressure and causing sciatica pain. This is the disc between L4 and this is the nerve root of L5. So when it protrudes under the cause pressure on nerve root, it causes pain. So you can see the fiber cartography in the cervical region, how the C3, C4, C5, C6, C7, C8, T1. The C5 to T1 rami of C5 to T1 join to form the brachial plexus. As you know, the spinal ventral rami and the dorsal rami. Dorsal rami supply. So this is a cadaver of spinal cord. You can see the real terminal part of the spinal cord, which we learned is at the L1 to L2 is called cauda equina. This terminal part of the spinal cord is called conus medullaris, below the lumbar enlargement of the spinal cord. And you can see the L5 vertebrae here, and you can see the various abdominal organs, the liver, the stomach in the Sag picture, Sag cut of the cadaver section. So this is another depiction of the same, because this anatomy is very, very important. You'll all have to learn this anatomy clearly. And you see, this is the pedicule of the vertebral body in the coronal plane. And you can see the L4 giving exiting below L4. This is L5 vertebral pedicule, L5 exiting below the S1, exiting below S1, S2, S3, S4, S5, and the coccygeal. So the pedicles, the ventral sacral foramina, you can see the spinal nerves, ventral rami. And then, as you remember, this is a must to remember that spinal nerve, which is exiting from the intervertebral foramina, divides into ventral rami that form the plexus, right? And you can see the plexus which is formed. This is a femoral nerve. This is the upper lumbosacral plexus, and the lower limb. This is the sciatic nerve, which is from the lumbosacral lower sacral plexus, and this is the phylum terminal, which we studied, which is the result of the regression of the caudal end of the spinal cord. And these are the cauda equina, and there will be problems which is called equina syndrome and conus medullary compressive myelopathy, and we will be learning them in the next classes. So you can see the spinal cord anatomy on the MRI. This is the cisterna magna, and you can see the fourth ventricle, the medulla oblongata. This is the sagittal view of T2 weighted image of MR, and you can see the intervertebral discs here, and the subarachnoid space. This is the T2 image. That's why the MR is CSF is shown as whitish, and this grayish one is the spinal cord, which is visible. And this is the cervical region. And look at the lumbar region. This is the conus medullaris, and this is a cauda equina. And this is a lumbar cistern, means it is a CSF filled space. And you can see the intervertebral discs also. This is the MRI of the spinal cord in the cervical and lumbar regions. And you can see that there is a pathology that is causing pressure effect on the epidural. This is the epidural abscess, which can cause quadriparesis. And you can see that there is a destruction of the vertebra. This is causing extradural compression with collection here and causing pressure on the spinal cord, causing quadriparesis. So whenever there is a pressure, it is a compression. Compression can be because of the problems in the vertebral canal. When it is called extradural compression, the compression can be intradural. That means intradural but extramedullary. Outside the spinal cord but inside the vertebral canal is intradural extramedullary, or compression can be from within the spinal cord when we call it intramedullary. The three types of compressions which you are supposed to learn. And you can see the dorsal root ganglion, which is getting the action potentials from the receptors which enter the spinal cord through the dorsal root ganglion, and they cross into the anterior part on the central canal and ascend up in the spinothalamic tract. So there are two types of sensations that enter. One is the superficial sensation, that is pain, temperature, and touch, and these will ascend through the spinothalamic tract, whereas The posterior column sensations, those are proprioceptive sensations. They ascend in the ipsilateral posterior columns, which are not crossed in the spinal cord, but they cross at the cranial end of the spinal cord. And this particular anatomy is worth remembering because it is responsible for the diagnosis of Brown-Séquard syndrome, and which you will learn in next class. The spinal nerve is, which is the ventral root. There is a law called Bell-Megendie law, which says and the ventral are always motor, right? And you can again see the epidural sheath of the spinal nerve. Again and again, I keep telling that the spinal nerve divides into ventral ramus and the dorsal ramus. The dorsal ramus turns back and supplies the paraspinal muscles. The ventral rami join to form the brachial plexus in the cervical region, and they form the lumbosacral plexus in lumbosacral region. This is the intervertebral disc in the axial section. You can see the disc, you can see the pyometer, which is closely approximated to the spinal cord, and the arachnoid meter and the durameter, and epidural space, which has got some veins, epidural venous plexus. And this is the facet joint, which can develop osteophytes and cause compression. And these are the vertebral vessels which you are seeing. So this is an interesting anatomy to learn about the spinal cord. And spinal cord is organized with gray matter located centrally. This is the central gray matter, and this is the central gray matter, and white matter is located peripherally. These are the dorsal columns which you are seeing, the ventral and the lateral. So gray matter is located centrally, and you can see the gray matter distribution in the cervical region, in the thoracic region, in the lumbar region, and the sacral region. This distribution keeps on changing, and there will be the gray matter is divided into various cell groups based on rexid lamina, which we'll show you in the next things. So now you look at the cross section. The thoracic posterior column of Clark's nuclei are present here, which are important in mediating the tone. This is the intermediolateral column C8 to T3, which is responsible for sympathetic outflow. This is the anterior ventral horn. This is the posterior dorsal horn, and there are various lateral column tracts which you will come to know. The posterior gray column, sensory processing interneurons and relay neurons. The lateral gray intermediolateral column, autonomic preganglionic neurons, thoracolumbar, sympathetic, sacral, parasympathetic. The anterior gray column has cervical and lumbar enlargements. So that's the spinal cord gray column distribution which you have studied, and you can revise it by, you can see that these are the white matter tracts. And if you are asked what is the gray matter in the spinal cord, this is the central part which I am depicting here. The spinal motor neurons are placed ventrally. The dorsal neurons are the sensory inputs into the spinal cord, and autonomic neurons are in the intermediolateral, right? The proprioception, the joint position sense, 2-point discrimination, and deep touch are conducted ipsilaterally in the posterior columns. The corticospinal tract is getting down the impulses from the cortex. The spinothalamic tract is ascending tract conducting the sensations superficial. And I am telling you that the gray matter in the spinal cord is divided into columns. They're called rexid laminae. Rexid laminae are the gray matter columns which are present, and you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. And 10 is all around the central canal, and this is the posterior thoracic nucleus or Clark's nucleus. This is gelatinosa, substantia gelatinosa. These are the marginal zones. These are intermediate lateral columns, and these are the ventral horns and the antihorn cells. So this is the distribution of the gray matter of the spinal cord. Pathologies can involve the gray matter or white matter separately or together also. The viral infections usually affect the gray matter, right? And you see how the rexid laminae 1, 2, 3, 4, 5, and 6. The posterior column nuclei, that is getting the proprioceptive sensations, the mechanoreceptors type 1 and type 2 are ending in 2, 3, and 4 rexid laminae. the alpha, delta, and C nociceptors are pain. These are ending in the 1, 2, 3, 4, and 5, and also visceral afferents. See, the thing to understand is spinothalamic tract is a cross tract, and the posterior columns are not cross or ipsilateral. You can see that temperature, lateral spinothalamic tract, pain, lateral spinothalamic tract. This is originating from the leg. This is the trunk. This is the arm, and this is the neck, and this is the touch. So this is a spinothalamic tract distribution, and at cervical level, the spinothalamic distribution is CTLS. CTLS means lateral part is the leg and neck is the medial part. Though, so distribution is very important to remember. The lamination of the spinothalamic tract in the cervical region is CTLS, because if there is a pathology in this gray matter, the sensations are mostly affected in the cervical region. If the pathology is intradural and pressing on the spinal cord, then the sensations of the sacral region are affected first in the cervical spinal cord. So the sensations that are conducted from the legs, from the thorax, they ascend through the spinothalamic tract to the brain. But at cervical region, there is a lamination, which you should understand, CTLS. So now we'll go on to the dermatomes. So the spinal cord is 31 segments. Each segment has its distribution of a myotome, dermatome, and vasotome. So all students should know what are the key dermatomes. The dermatome maps vary and slightly overlap. They can test light touch and pen prick. Pin should be tested with single pokes, not repeatedly. Use face as a control. So only one pick should be given, not repeatedly. For that, you should understand what are the dermatomes. And you see the key dermatomes of this figure. You can see the C3, which is in the neck, C4 in the applet region we call, and C2 is here. C1 is not available. You can see C2 is on the back of the head. On the neck, C4, C3, and on the arm, lateral aspect is C5, and in the thumb it is C6, middle finger is C7, little finger is C8, and medial aspect of the arm is T1, and at nipple it is T4, at umbilicus it is T10, at groin is L1, over the knee it is L4, and over the dorsum of the foot is L5, and back of the popliteal fossa, you see that it is S2 and S1. So you can see the S2, 3, 4 on the perianal regions. Lateral border of the foot is LS1. So S1. So these are the important dermatomes which you should remember, which I'll show you again. And you can see the specific. Want to examine dermatome? That's the point you should examine. You want to examine C3? This is a point you should examine. You want to examine C4? This is a point you should examine. So dermatomal type of sensory loss is encountered in radicular pathologies. See, the sensory loss can be because of a damage to the peripheral nerve or a damage to the spinal nerve, which is in the intervertebral foramina, when we call it as radiculopathy, or the sensory loss can be because of a problem in spinal, in the spinothalamic tract, or the sensory loss can be in the patellar. C4. Now you look at C8, C7. C6 is thumb, C7 is the middle finger, C8 is little finger, and you can see the T1 on the middle aspect of one, C5 on the lateral aspect, T2 in the axilla, and you can see the C3, the C4, T4 at the nipple level, T10 at the umbilical. So these are the sensations which these sensations are affected in the conus medullaris. So there is a term called sacral preservation sensation, sacral loss of sensations, and that will give you a localization. So this is the S2, S3, S4, S5, and you can see the pain and temperature fibers. They cross in front of the central canal. So each sensory tract has three neurons. So the first order neuron, the second order neuron, the third order neuron. The first order neuron is in the dorsal root ganglion. The neuron has two processes. The peripheral process is attached to the receptor in the skin or subcutaneous tissue. When that receptor gets stimulated, action potentials get conducted into the dorsal root ganglion. The central process conducts into the spinal cord at the level or one or two levels above and in the substantia gelatinosa or the rexid lamina 1, 2, 3, 4, 5. And the second order neuron starts from there, crosses in front of the central canal and ascends up in the spinothalamic tract and goes up to the thalamus unchecked, and there the third order neuron starts and goes to the parietal lobe. So three neurons in the superficial sensations, which we enumerate as a pain, temperature, and light touch. Okay, that is a superficial sensation. On the other hand, the proprioception, that is the joint sensations, the vibration sense, the 2-point discrimination, they get conducted from the periphery into the dorsal root ganglion, and the central process enters the spinal cord. It doesn't synapse there. It ascends up into the nucleus gracilis or cuneatus at the end of the spinal cord in cranial direction. From there, the second order neurons start. They cross to the other side and ascend in the lemniscal pathways to the thalamus. From the thalamus, the third order neuron enters the parietal lobe. So this is in essence the sensation ascending tracts. So the dorsal columns are seen here. You see that the dorsal column sensations are not crossed, they ascend in the posterior columns. Okay, and you see the now this unfortunately this is a muscle chart which we'll discuss later, but the flexors, the extensors of the fibers which are coming from the corticospine, the anterior horn cells which are there in the ventral root, they are supplying the central region, the ventrolateral region, the dorsolateral region, the retrodorsal region. They got a functional distribution. So the flexors of the hand and foot, extensors of the hand and foot. Flexors forearm, extensor forearm and leg. The flexors of arm and thigh, extensor of arm and thigh. Flexors of trunk and extensor of trunk. So the distribution of the anterior horn cells, which is misplaced here, but that's because this is already a tracts which are coming. This is the dorsolateral, this is the ipsilateral tracts, this is the ipsilateral corticospinal tract, and this is the contralateral spinothalamic tract, which we'll discuss more. So the gracilis, fasciculus gracilis and cuneatus, and the crossed levels and partly crossed and uncrossed are depicted, which these are the tracts which we are going to discuss in the next thing. And the motor tracts are coming from the upper motor neurons from the brain, that is the bed cells in the cerebral cortex and also in the centers in the brain stem. They cross at the level of medullary pyramid, and descend in the lateral corticospinal tracts and home on to the ventral horn cells to the final common pathway, that is the lower motor neuron. And those impulses carry out elbow flexion, C5, elbow flexion, wrist extension, C6, elbow extension, C7, C5, C7, finger flexion, T8, finger abduction, T1 in the upper limb. Similarly, this is you see the shoulder, C5, C6, C7, and elbow flexion, C5, C6, extension, C7, C8. You can remember it that way. The shoulder, the abduction and shoulder adduction, the radio ulnar and the wrist movements, you can see C7, C8. The wrist is basically C6, C7, extension, wrist dorsiflexion, plantar flexion. The digits are C8, T1. So C5, C6 is at the level of a shoulder and elbow, C6, C7 at the level of the wrist, C8, T1 at the level of the fingers. And similarly, the lower limb, the hip flexion is affected by the spinal segments of L1 and L2, the knee extension by L3, the ankle dorsiflexion by L4, the great toe extension by L5, and ankle plantar flexion by S1. See, you see, this is a gradual. The knee extension, ankle dorsiflexion, great toe extension, ankle plantar flexion, and these can be seen in the following diagrams, how the L2-3 is doing the hip flexion and extension. The knee extension and knee flexion by L3-4, L5, S1, L4, L5, ankle dorsiflexion, plantar flexion, S1-2, gastrocnemius and soleus muscles, and these are the subtalar joints which are implementing the medial and lateral rotation. So these are the muscles. The spinal segmental control of the limb movements is to be remembered for localization purposes. So you can see the withdrawal reflex, and that is the crossed extensor reflex, and these are the fibers that are coming from the foot. If your foot lands on in a say some pin or something which hurts you, the impulses will get carried to 1 alpha sensory afferents, and they enter the spinal cord into the rexid lamina 2, 3, 4, and from there the interneurons take it to the ventral horn cells, and some of them inhibitory, some of them are excitatory, and similarly the crossed thing also goes to the other side, which will affect the extensors. So the limb is flexed, the other limb extends to support the body weight. This is a withdrawal reflex. So the spinal cord gray matter is very, very important in mediating this. And what I said earlier, the lamination of the spinothalamic tract and the pyramidal tracts is very well depicted here. You see the posterior columns. The sacral fibers are placed medially, and this is CTLS. This is a reversal of CTLS, that is spinothalamic tract. The spinothalamic tracts, you see that this is a spinothalamic tract and CTLS here, and this is the spinothalamic tract CTLS, that is sacral region, posterior columns medial, and sacral region, spinothalamic tract lateral. And similarly, the corticospinal tract, the sacral region is lateral, cervical is medial. So you can see this lamination is very important. There are some very, very important tracts: rubrospinal, reticulospinal, olivospinal, and vestibulospinal. These are the anteriorly placed or ventrally placed tracts, which are also implementing the stability in the trunk. They are also the extra pyramidal tracts, which are carrying the balancing act. And you can see the spino-olivary fibers, the anterior spinothalamic tract, and spinocerebellar tracts, which are mediating the muscle tone through Clark's nucleus, and the spinocerebellar tracts enter the cerebellum, and from there the dentatorubrothalamocortical tract takes it to the cortex, and the corticopontocerebellar tract brings it back to the cerebellum, and the spinocerebellar tracts are affecting the balance of the movement, right? So these are the ascending tracts, and the ascending tracts, if you in a nutshell, are the dorsal white column, which ends in the fasciculus gracilis and cuneatus, from where the second order neuron takes place. The lemniscal pathways goes to the thalamus, and then it goes to the parietal lobe. The dorsal spinocerebellar tract, ventral spinocerebellar tract, which are originating in the Clark's column, the lateral spinothalamic tract and ventral spinothalamic tract. These are the ascending tracts. So the descending tracts are lateral corticospinal tract and the reticulospinal tract, the rubrospinal tract, the medial reticulospinal, ventral corticospinal tract, vestibulospinal tracts. So the reticulospinal, vestibulospinal, rubrospinal tracts are also all the descending tracts. So these are the summaries of the tracts. You can again revise: the posterior columns are ascending tracts. This is the Lissert's tract or dorsolateral fasciculus, which you can see here. The spinocerebellar tracts, the anterolateral system, which includes spinothalamic, spinoreticular, spinomesencephalic, spinotectal, spinohypothalamic fibers, they all get ascended. The spinocerebellar tract is placed anteriorly also, and anterior commissure is seen here. This is anterior commissure, and you can see for the benefit of clarity, it is divided on both sides, but both sides are ascending and descending tracts. The descending tracts are corticospinal, rubrospinal, and also the reticulospinal and vestibulospinal, tectospinal. These are the descending tracts, and you also have the autonomic fibers. The segmental features may help in localization. The pain, band-like circumferential discomfort, segmental radicular sensory loss or pain, segmental lower motor signs. That means a person with spinal cord disorders will present with pain or a band-like circumferential discomfort or a segmental or radicular sensory loss or pain, or segmental lower motor sign. That means if there is a problem or a tumor in the T4 or T5 vertebral level, which is causing pressure on the spinal cord, which is inside the vertebral canal, this spinal cord is around 1 centimeter in diameter, and a pressure which is coming from the tumor like meningiomas, it will cause at that level a lower motor neuron type of signs, which consists of wasting, weakness, fasciculations, and below that level there will be UMN type where spasticity predominates with exaggerated reflexes and upgoing plantar. So the dorsal column's deficit is ipsilateral to the lesion and below it. The lateral corticospinal tract deficit is ipsilateral to the lesion and below it. The spinothalamic tract deficit is contralateral to the lesion and below it, because the tract is already crossed when it is formed. The cord has so much more of clinical and functional importance. So the Brown-Sequard syndrome has got ipsilateral loss of pain, weakness, and ipsilateral loss of posterior column sensation or proprioception, and a contralateral pain and temperature sensation loss. And you can see the vascular supply now. The last segment of this talk is about the vascular supply, and you can see the watershed area is at T4 level, and these arteries I'm going to describe later, just have a general idea. It's basically the arch of aorta and the descending aorta, which is giving rise to the branches which will help supplement the blood supply of the spinal cord, which is coming from anterior spinal artery and also posterior spinal arteries, which are paired. So you can see that the ascending cervical, the deep cervical artery, the intercostal arteries are also joining. The dorsal and ventral radicular arteries, which are coming from the aorta. The biggest of them is called Adam Quigg's, the greater segmental medullary artery of anterior region, and these are the anterior segmental arteries. So the rich supply, the posterior segmental medullary arteries, posterior intercostal artery, and these are all supplements to the anterior spinal artery, which is the one single one, and two posterior spinal arteries. You can see in another depiction here, this is the anterior spinal artery, and radiculomedullary artery branches are coming, and there is a pile network, and this supplies this is a vertebral column, and this is spinal cord. These are the nerves, and this is arch of aorta. Then from there, the branches are coming and supplying the spinal cord. You can see the diagram, and this is a radicularis magna or artery of Adam Quigg's at the L1 level, which is supplying the lower part of the spinal cord, supplementing that, whatever blood supply of anterior spinal artery and the posterior spinal arteries are coming, causing this. And you can see the diagram clearly, the network of the posterior spinal arteries, which are here and here, and the anterior spinal artery in the anterior. This is a sulcus, this is a gray matter of the spinal cord, which is seen, and you can see plexus of the matters, the Dural matter and epidural venous plexus. Internal vertebral venous plexus are the Baston's plexus. This is the plexus, the veins which are draining the spinal cord. The importance is the Baston's venous plexus is connected to the cranium also. So easily the metastasis can go to brain through the venous plexus, which are surrounding the spinal cord in the epidural space. And you can see the anterior spinal artery here, and this is the central artery, the pile artery. See, there are branches which are coming from either side, and this way there's a rich supply of the blood, oxygenated blood to the spinal cord, and there will be spinal cord infarcts, there will be spinal cord ischemias because of dural AV malformations. And you see the color is different. This is anterior spinal artery which is coming here, and radiculomedullary artery of Adam Quiggs at L1 level is supplementing the blood supply to the spinal cord, and this circumferentially the branches are going all around the spinal cord, and the radial branches enter the gray matter all around and supply the spinal cord. And you see the central artery also branching and supplying. There is an anastomosis here, so there is a type of watershed area in the spinal cord. And you can see the same diagram, and you can have the area supplied by the posterior spinal artery and area supplied by the anterior spinal artery. This is the area supplied by posterior spinal artery, and this is the area supplied by anterior spinal artery on both sides. So anterior spinal artery syndromes will affect the spinothalamic and the corticospinal tract. The posterior spinal artery syndromes apply only the dorsal column. So that's how you diagnose, and you can see that the importance of this blood supply is re-emphasized here. You can see the anterolateral system here and the lateral corticospinal tract system, the fasciculus scincter, the posterior columns here, and you see the segmental artery, the anterior radiculomedullary artery, and this is anterior spinal artery, and the arterial vasa corona, which are entering and supplying richly. This is the posterior radiculomedullary artery, and this is the posterior spinal artery. There are two posterior spinal arteries. The other side is not shown. One anterior spinal artery, two posterior spinal arteries, and there is a rich venous drainage of the spinal cord segment, which I have already described, that the western plexus is very, very important the metastasis from the lower down the abdomen to the brain. And you can see that this is the arachnoid mater, the pyometer is surrounding the spinal cord, and this is the dura mater, and this is a venous plexus, extradural venous plexus or Batson's plexus, and you can see the intervertebral disc, and this is the C6 vertebral level, and the dorsal root ganglion, and the dorsal ramus, and the ventral ramus, which we discussed a lot, and the dorsal intradural venous malformations. You can see various types of valve malformations in the blood supply, the complex extradural, intradural spinal AV malformation, which can give rise to infarctions of the spinal cord because of the poor blood supply. And you can see the radicular, this is the fistula, this is spinal dural AV fistula, and it's located within the leaflets of the dura mater, the nerve root sleeve, and is formed by the abnormal connection between a radicular artery and a radiculomedullary vein, which is a tributary of the coronal venous plexus. So the vein has become dilated and tortuous due to its direct exposure to the arterial pressure. And you see that will cause spinal cord infarction, and you have to occlude it with glue to protect the spinal cord. The spinal cord syndromes can be diagnosed as the central cord syndrome. You can see the central cord syndrome. This is caused by syringomyelia. Anterior spinal cord syndrome, which you can see here, and this is a cord infarct. The hemicard or Brown-Sequard syndrome, because the trauma or tumor, the areas, and you can see the descending tracts that are involved in the central cord syndrome are these, and that means the gray matter is mainly involved. You have the white matter involvement subsequently is spared, but the gray matter is involved in the anterior. This is the posterior part. Descending tracts are involved, and you can see the central cord syndrome, Brown-Sequard syndrome, anterior spinal artery syndrome. These are the most common things which you see in the spinal cord disorders, which we'll discuss at greater length later on. And this is the what I'm talking about, anterior spinal artery syndrome. This is the posterior spinal artery syndrome, where these tracts are affected. And you can see the Brown-Sequard syndrome, where you have problems, as I said, ipsilateral spinal tract features, posterior features, laminations, and you can see the spinal cord showing a cervical spondylotic myelopathy, And you can see the syringomyelia, which is seen in the MRI of this. And so let's look at the compressive myelopathy. Compressive myelopathy means tumors. Just listen to me. The compressive myelopathy is divided into extradural compression, interdural extramedullary, and intramedullary. The extradural compression is mainly because of infections, that is spot spine or osteomyelitis or epidural abscess. There may be bacterial fungal infections which can cause this. The second extradural compression cause is neoplasms. Out of the neoplasms, the most important are the metastasis are most common from lung, breast, and prostate, and they can metastasize and cause problems at various levels of the spine. So whenever you suspect metastasis, the entire spine has to be screened. That is the neoplasm. First cause is metastasis. The second cause is primary malignancies of the bone, that is multiple myeloma, most important. There is no other primary neoplasm, malignant neoplasm that occurs, but multiple myeloma is the most important. The benign neoplasms of osteomas and chordomas are very less common in this case. And so that's one. And the other one that causes the compression is mostly fluorosis, skeletal fluorosis, which will have a lot of the fluorosis causes calcification of the vertebral column and also the ligaments, and the spine becomes very stiff, and the skeleton is ossified. So that's it. And cervical disc prolapse, cervical canal stenosis with multiple disc prolapses also cause extradural compressions. Intradural extramedullary, there are mainly two causes, that is meningiomas and schwannomas, which will cause a picture like bone Sequard syndrome. And intramedullary, there are only two causes which you should remember: ependymomas and astrocytomas. So the DD is narrow and can be diagnosed with the combination of a thorough history, accurate examination, and MRI. MRI is the criterion standard imaging modality in the workup of myelopathy and should be obtained expeditiously and very fast. The back pain is a common complaint. And one point you should understand is the presence of night pain suggests metastatic or primary neoplasm. The direct examination of the spine, spinal tenderness, and gibbous is useful in the workup of myelopathy. The spinal pain is not throughout the day, and it is not relieved by rest. It is present throughout the day, unlike the degenerative pain, which is more in the evening. The surgery followed by radiotherapy is an important aspect. You can see the metastatic tumors in the T1 vertebrae. This is a metastatic tumor that is present, and you can see the axial sections here, and you can see the operative pathology there. And intradural extramedullary tumors, that is a meningioma, which you can see the meningiomas here, and you can see the tumor here, and this is a spinal cord which is getting compressed, and this has been operated. So the osteogenic, osteoclastic, chondroblastic, fibroblastic true bone tumors are there. The vascular hemangiomas, aneurysmal bone cysts, hemangioparasitomas, notochordomas, plasmacytoma is more important, myeloma, and these are the primary malignant bone tumors. Lipomas and angiolipomas are very uncommon. Okay. So the common symptoms are clumsy cervical spondylotic myelopathy, which we'll see in the advanced ages of 65 and 70. It presents insidiously with clumsy or weak hands, leg weakness or stiffness, neck stiffness, pain in the shoulders or arms, and unsteady gait, atrophy of the hand musculature, hyperreflexia, and alarmit sign, electric shock-like sensation down the center of the back following flexion of the neck. That's the most important sign. And there will be sensory loss depending on the brown Sequard fashion or a sensory level that can be present. So that's the cervical spondylotic myelopathy, which can happen, right? And you can see that this is the canal that is getting narrowed because of the various disc prolapses. This is the intervertebral disc between the two vertebrae, which is pressing on the spinal cord. And I said the primary spinal cord tumors, intramedullary is ependymomas, and you also have intramedullary astrocytomas, pilocytic astrocytoma, and intradural extramedullary is meningiomas and schwannomas, neurofibromas, myxopapillary ependymomas, extradural tumors, also present en-bloc meningiomas. So the spinal cord tumors and lung, breast, prostate, thyroid, and renal cell cancers are the majority of the metastatic tumors to the spine. The most common tumor is metastasis to the spine. The primary spinal cord tumors, adult or meningeal tumors, followed by nerve sheath tumors and ependymal tumors. In children and adolescents, it's ependymomas, which are common, followed by astrocytomas and other neuroepithelial tumors. So intradural extramedullary meningioma schwannoma. Intramedullary ependymoma and astrocytoma. At adults, it's ependymoma. Children, it is astrocytoma. Ependymomas originate from the radial glial stem cells. The classic histological features of grade 2 and grade 3 WHO are perivascular pseudoracetes, in which tumor cells are arranged around the blood vessels in a spoke wheel pattern. Right? And this is the ependymoma, which you can see 1/3 of the ependymomas have a rim of extreme low signal hypointensity at the poles of the tumor due to hemostatin deposition called the cap sign. The cap sign is seen here in ependymoma, and which is a common intramedullary tumor. Ependymomas, intramedullary tumor, glioblastoma, that is arising from the astrocytes, astrocytoma, glioblastoma, and this is a meningioma, which is the interdural extramedullary tumor. And interdural extramedullary tumor, myxopapillary ependymoma, which you can see here. And spinal metastasis, as I said, extradural metastasis, lung, breast, prostate, thyroid, renal, leptomeningeal, breast, lung, melanoma, and intramedullary metastasis, lung and melanoma and prostate. So the spinal metastasis, the nasal carcinoma, you can see that this is coming here and causing a lot of destruction in the spinal cord and causing severe pain. Drop metastasis, left turn. So inside the cranium, if there is a tumor, that can cause drop metastasis, but no, this cannot go out. It cannot cross the blood-brain barrier. The intracranial or the brain parenchymal tumors don't metastasize outside the brain, but they cause drop metastasis into the spinal subarachnoid space. Though metastatic tumors are most common spinal tumors, extradural, leptomeningeal, and intramedullary. The extradural spinal metastasis typically presents as axial pain and can be differentiated from the primary back pain as it is not associated with activity or position. It is not improved by rest, does not respond to conservative treatment, and gets progressively worse. If an epidural spinal metastasis is suspected, the entire spine should be imaged, as I said earlier, as 1/3 of the patients will have multifocal disease and is not reliably localized on neurological examination. So if you suspect this, you have to image the whole thing. The leptomeningeal calcinomatosis has a predilection for the cauda equina because of the effect of gravity and a reduction in the CSF circulation. In the next class, we'll differentiate between conus medullaris and cauda equina syndromes. And intramedullary spinal metastasis appears as well as circumambulatory lesion with marked edema and usually without associated cysts. It's a ring enhancing on post-contrast MRI. So these are the genetic neurofibromatosis, schwannomatosis, von Hippel-Lindau disease. So in any neurological assessment, you have to look for neurocutaneous syndrome markers, and those are many, and we'll discuss in due course of time. So that finishes our class today of the spinal cord part 1. And if there are anything which you want to ask, you can ask, or you can meet me in person. At the end of the 3 lectures of spinal cord, there is a seminar that is to be held by you chaps and the 8th sem students. So please meet me, and 4 of you or 6 of you who are interested in participating in this seminar and presenting, and from after 2 more classes. The first class, there will be 2 more classes in spinal cord. The 4th class will be the student seminar of the postgraduates, and you can come. Everything is clear, I think, and no doubt you can come and meet me anytime. Yes, anybody wants to say anything? Shall I close? Okay then. Bye.
Thank you,
Have a
sir.
good day.
Thank you, sir.
Yes, yes, yes. You are saying something? Hello? Not able to hear. Will you raise your hand or type? Okay, thank you.